Thank you for having me, and it's going to be great having Connie in San Diego next year. Oh, I'm just kidding. And I appreciate the opportunity to come. And right as Dr. Hamid said, we share a lineage, my father. My father died this year from cancer, and he participated in clinical trials. And it's amazing how things kind of meld together. And it's a little emotional for me coming back to Los Angeles because this is his hometown. And so I'm going to talk about melanoma. I'm in San Diego. I do melanoma. I do skin cancers. I'm also at the VA. And what I love about these events is they're collaborative. So you guys are here not because you love spending Saturdays at this hotel, but that you're interested in the topic, and we want to learn from you. So I expect questions and hard questions later in Dr. Hamid's show. So, before I forget, hello to Portugal. So what I'm going to talk about is cancer, and mainly focus on the immune system, because that's why I got into oncology, was to look at the immune system. I know there's lots of other ways to go after cancer, surgery, targeted therapies, things like that, but I'm going to focus down on the immune system. And just an overview of current therapies and then clinical trials, because I got a few different emails about what I was supposed to talk about, and so I just moved it all together. And in melanoma, we have the targeted therapies that go after the inner workings of the cancer cell, and those are the BRAF drugs that you just heard about that are used, and then the external cells participating, and those are the immune system and the interaction there, and some of the tools we have to address that. I grew up in the lab. And just as Dr. Hamid's about to torture his 13-year-old by coming in and doing stuff, I was also tortured and did stuff, but it steered me towards the lab. Eventually I came around to really loving the clinic. So I'm going to take you through a case. And it's a case, as Dr. Hamid said, we're still looking for answers. We have some, but not enough. And so we've shared patients. And this is a patient that we shared. This is a young gal who had a history of a lesion on her neck. It was melanoma. It was advanced at the time. She had scans, and at an outside institution, she got some therapies at the time, which was not too long ago, were still in use and considered standard, and we don't do it anymore. That was like 3 or 4 years ago. So it's completely changed. And now we have, as has been mentioned, Imlygic or TVEC. These are injectables. We have the checkpoint inhibitors, whether it's PD-1 or CTLA-4. There are a few people out there that still give IL-2. They're getting old and tired. And then the targeted therapies, there's too many to list, so I just list the pathway, which is the BRAF and the MEK pathway inhibitors. And it's cut off, unfortunately, but Dr. Hamid just published this great study looking at some of the early data for pembrolizumab, 5-year data showing that patients who got exposed to these medications early on have been followed for a while and have been able to get off the medication and continue to live without cancer. Again, unfortunately, that curve does drop down. That's not 100% of the patients respond, not 100% of the patients get a complete response, but we are starting to get some hope there that patients are going to be able to have a drug-free, cancer-free survival after experiencing metastatic disease. Sorry. The other immune therapies besides that PD-1 blockade is PD-1 and CTLA-4, so affectionately known as Ipi-Nivo or Yervoy-Opdivo, and that's also trying to raise that bar up for patients to both respond and have long-term survival. This is just some updated clinical trial data. But again, more importantly is the idea that you can treat somebody and get them off medications and not have the cancer come back. And I was just speaking to, I won't point them out, but there's people in the room that have had CTLA-4 and are now getting scanned once a year or maybe not scanned at all, and just going by symptomatic observations. So that's the hope. And so in this gal's journey, after progressing on some of the older therapies, she began nivolumab, got some benefit for a little while, and then their docs sprinkled in some Yervoy or ipilimumab, but it didn't work in this particular case. She was genetically studied, at least the tumor was. It's a standard of care now. I'm sure people have had their tumors sequenced. And she had a BRAF alteration, but not felt probably responsive to a BRAF inhibitor, so she got a MEK inhibitor, but unfortunately didn't tolerate it and progressed. So when we're thinking about these stories, you know, okay, she had kind of the best stuff. Why didn't it work? Good question. And smart people like Tony Rebus over at UCLA, sorry, Hamid, plug in somebody else for a second, have outlined these networks of interaction of, this is a T-cell centric kind of look at the world with that CD8 T-cell in the middle, and that tumor putting out its defensive mechanisms against being attacked by the T-cell. And there are many steps that you don't need to see, but many steps that are along in this conversation that's going on within the tumor. And so what Tony's been able to do, obviously in labs and collaboration with a lot of people, is to get these signatures where you can tell if there's an inflamed tumor or a not inflamed tumor, what steps are going on within the tumor. And the hope is with this understanding we can either redirect therapies or avoid exposing people to therapies that they might not need, and just get them, as Alex said earlier, you know, the right therapy at the right time to the right patient. So these tools are coming along, but unfortunately not quite there yet, because Dr. Hamid took what Dr. Rebus had looked at and applied it back to that set of patients with, that were treated with pembrolizumab. And this data ended up in his supplemental section because while it's interesting, it just wasn't good enough to help pick out these patients in this particular technology at this particular time. But it does enrich for those patients that would respond. So I'm going to come back to this theme, but just to show you that when a tumor's interacting with the world, it does it in many different complex ways. So not only is every patient different, but tumors are different within the patient, and even where they live, they start to evolve and be different, and so it gets to be a challenging problem. So some of the challenges, do they have T cells that are in the tumor? Do they have regulatory cells that are there? Do they have these interferon pathways induced? Are there other checkpoints and other mechanisms? And the answer is yes, all of the above. And so the focus is to try to figure out those pathways and then keep moving a tumor towards the cliff and push it over. And that's whether trying to stress it with even the old treatments like chemotherapies or targeted therapies, or some of these new agents that we're getting ideas on that Dr. Mead will outline soon, looking at really in a granular level these cellular signaling pathways and saying, oh, STING, I know that. That's rock. No, that's a molecule in the cell that turns on this interferon pathway. So now we have STING agonists to turn on these pathways and try to get the inflammation to what's called a cold tumor. Because, well, again, great progress has been made. Sorry, my pointer's not working, but we're still not addressing almost half the patients. We're not getting that answer that's leading to that long-term disease-free survival. So into the clinical trial world we go, and this patient at the time, as you saw, was progressing on standard therapies, and so, you know, a year and a half ago, the field was excited about the idea of this molecule, and T cells are dependent on amino acids, certain amino acids to be present. Tumors can change the amount of those amino acids, so we fought back with inhibitors of those pathways. And this was the IDO story. And a big clinical trial got going because early data suggested that this looked pretty promising. So promising that she got on her car and came up here to get on this study. And so unfortunately, again, you don't need to read all the details, she progressed shortly after coming on to this clinical trial. And it bore out that, not that we want to base our lives on anecdotes, but it turns out that she wasn't an anecdote, that while the early clinical trial data suggested that IDO inhibitors were helpful, this was pretty definitive for this compound to show that it did not help adding it to checkpoint inhibitors. And so this takes a lot of work. It's complicated. And again, I'll just say that we appreciate everybody's participation in these challenging questions, because we need the answers to avoid doing the wrong thing sometimes. But back to our gal. So she's progressing. What do we do? Ideally, we get her on a clinical study. One was not available at the time for her, so she went through ipi-nivo again, even though she'd been exposed in the past, and had some radiation to a symptomatic lesion. And the hope was, as the graph points out, that sometimes by combining radiation, or as Dr. Ferry said, surgery, or other tumor irritating events, that you can enhance the benefit of your immune therapies. And that's what the graph shows. But it didn't show for her. She continued to progress. Keep going on, try to find another study. This is a study looking at a way to change the microenvironment in the tumor. In this particular case, it's injecting in a DNA that encodes IL-12. So Dr. Dowd up at UCSF has pioneered this. And with this DNA, the tumors take it up and then express this cytokine locally. And it changes the microenvironment to a very inflamed, active microenvironment. The problem with this that I have is that to get that DNA into the tumor, I'm just clicking through some of these, is you have to electroporate it in. That's a hard concept to explain to a patient, but you inject the DNA and then you slip in this small probe with 6 sharp but small needles, and then you stand back and push the pedal. And there's a few clicks, and then some muscle spasms happen, and it can be kind of painful. But it's interesting technology. Hopefully that's not where this technology stops. And for her, it actually did show some benefit to the lesions that we were treating. But she went through this electroporation. We inflamed her tumor, and she progressed. So now what? This is some of the disease you might see on that's the back of the neck, and some scans showing some enlargement of lymph nodes. So an old drug, again mentioned by the previous speakers, interleukin-2. It's difficult to do. It's a hospital-based treatment. And we know when to stop giving it because we all get nervous that the next dose is leading to the ICU. But it's a mechanism that's in the immune system to reinvigorate T cells, expand T cells, and it's really not substituted by any of these checkpoints. So people have gone back and looked at interleukin-2, and one study is taking IL-2 and putting it in a complex. And this complex can be given as an IV infusion once every 3 weeks. And so it's a much kinder and gentler way to give IL-2 than to go into the hospital and get doses every 8 hours. And there's some cartoons saying that it expands the good T cells, but not the bad T cells. And some of mice and men data that show that we're doing things to the immune system and killing tumors in mice that we wanted to do. And then people, it has some activity too. So we thought, okay, that's great. Let's put her on this, this trial. and she didn't qualify. She didn't qualify because she'd already been exposed to interleukin-2, and that's what's one of the exclusions. Again, the challenges of trying to get patients onto clinical trials and the hard work that there is. About that time, another clinical trial was opening up, and this one was looking at isolating the cells that are in the tumor. Some of you may be familiar with this. This is called tumor-infiltrating lymphocytes, or TILs, or autologous cell therapy. And what you need from that is a tumor that you can easily excise. Well, she has that. And be refractory to everything. Well, she has that. So the tumor was resected, sent off to the company that's sponsoring this trial, Iovance, and 3 weeks later we got the green light that the cells were growing. This is some of the data that Dr. Rosenberg really pioneered at the NCI, showing in those patients that respond, sometimes some rapid responses that can happen. So a lump on this gentleman's side of the neck went away quickly, as well as some distant disease. And with this trial, this is trying to move it out of the NCI to the other people that are in the world, us mortals, to give this therapy some availability. And with the early cells that were given through this protocol, you can see some of the responses. The response in this case is on the downside of the graph. So she was admitted to the hospital after we got the green light. She was given some chemotherapies, got the cells, and then given a fixed number of doses of interleukin-2. And going in on September 25th, she went out on October 12th, and so that's 2 to 3 weeks in the hospital. It was complicated. It doesn't look complicated there, but it's complicated, and Dr. Hamid has a study going too. It's complicated. And she came back for follow-up, and she had the starting look on September 11th, and then a follow-up scan on February 8th, showing that that lesion on the back of her neck got smaller. So this is what we call TIL 1.0. Really, this, I shouldn't trivialize it. That's almost 4 decades of work to get into where we are for this technology, but it's expanding the T cells out and then transferring them back in, and there's chemotherapies involved, and it's complicated. So we're going for TIL 2.0. That's the hope, and what we hope to do is to select better the type of cells that would be going after the tumor. We think, like a lot of people think, that these are cells that go after what are called neoantigens, or mutations that are specific to the melanoma cells. And we'll take those selected for activity cells and go through that same cell therapy process. And so there are many slides out there that kind of reemphasize the problem that we all face, and that is cancer's complicated, and you got it in the middle, and the way that they fought back is different in different patients and different within the patient. And so trying to get that information out and tailor treatments. This is a slide that I think Dr. Hamid passed on to me, and I can only say that this great idea, it's just not working. And that's probably because we need more. What do we need? Maybe we need his son to grow up and do AI so that we can have networks integrated in. We can look at this on a dynamic basis, but it's a great start. And I hope that gives you a feel for where the field is. I left out about 600 other clinical trials, but he'll get to that at his talk. So I'd like to thank the patients, families, friends, and staff that make this possible. Thanks.